Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Today we are going to be talking about pulmonary embolism, or blood clot in the lungs. This is going to be a basics overview lecture. We'll go through the epidemiology, risk factors, pathophys, symptoms, clinical evaluation, management, prognosis, complications, tons and tons of stuff in here. So definitely stick around. Quick shout out to the channel. This is the channel Whiteboard Medicine. If you are new to the channel, this is our homepage. We do public health and medical education. Definitely check it out. We'd love for you to subscribe, hit the bell button, check out our other videos. We'll link some high yield playlists in this video's description. We also do a Patreon page. We'd love for you to check that out and support us. You can join for free. There's also some tiered memberships too. We post all of the video outlines, ad-free videos, practice questions on there. So that's linked in this video's description as well. We're trying to really buff up that community, so we'd love for you to check it out if you have an interest. No further ado, quick 30-second break for the introduction. Don't go anywhere, then we'll dive in. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So, pulmonary embolism, or blood clot in the lung. When we talk about pulmonary embolism, it's something that's really important for really everyone to know, us who work in healthcare, from all specters of the healthcare team to those just in the general public, because this can be a really serious, really deadly disease, and it's one that's pretty common too. And it's one that has symptoms that you can identify, think about, ways to diagnose it and treat it. And it's all things we're going to talk about in this video. So if we start with the epidemiology and just a quick description first. So when we talk about pulmonary embolism, we're talking about the lungs, right? Here are the lungs. We have two lungs. We have right, left, although it looks opposite to you. This is the trachea, or the windpipe that we breathe in. And this is the lung tissue. We call it kind of the lung parenchyma. Okay? And the lung parenchyma, just like any other tissue, needs blood flow. So sitting kind of the middle of the lungs, you have the heart, right atrium, right ventricle, left atrium, left ventricle. And the right side of the heart has blood vessels that come out of the right ventricle and bring blood to the lungs. So that right heart has blood that goes to the lungs. And within that, there's obviously multiple blood vessels that then go to the lungs, and they break off into kind of smaller and smaller and smaller blood vessels. Maybe black would be a better color so you can see it rather than red on red. So blood vessels, the pulmonary arteries, then break off into smaller and smaller blood vessels that all kind of perfuse the lungs. And if these blood vessels get blood clots in them, it cuts off blood flow to a portion of the lung. This is kind of a zoomed in look at that blood vessel. So all this blood is traveling through, and blood brings oxygen to the lung tissues. But if you get a blood clot in here and it plugs this up, this is a pulmonary embolism. And that means no blood flow can get through. And that lung tissue that is getting perfusion from that blood vessel no longer gets perfusion. And that can cause both lung injury, right? Lack of blood flow, ischemic tissue, and death of that tissues. And it can also cause something called a VQ mismatch, or ventilation perfusion mismatch, which we'll talk more about. When we think about how many people this affects, it's more common than you'd think, about 40 to 100 people, and this is probably an underestimate, per 100,000 people per year. It's the third most common cause of cardiovascular disease. Blood vessels are vascular. So even though it's in the lung, it's the third most common cause of cardiovascular disease in people. And it leads to more than 100,000 deaths. Ooh, deathy, that's interesting. This is most be deaths per year. So this is a common, and it's not like the flu common, but a fairly common disease. It can be a deadly disease. And when it's not deadly, it can cause a fair amount of morbidity or comorbidity, right? It can lead to right heart dysfunction. It can lead to chronic shortness of breath. It can lead to something called CTEPH. All things we're going to talk about in this video. All reasons to know what pulmonary embolism is. When we think about the risk factors, what can cause someone to get a pulmonary embolism? We start over here with something called Virchow's Triad. This is something they teach in, day one pre-med or medical school, and it's composed of 3 different things. And Virchow's Triad is a description of what can make blood vessels clot. And the first is hypercoagulability. This means that the blood is more coagulopathic. It can clot more easily because there's this dance going on in our blood vessels between procoagulant factors and anticoagulant factors. And this dance is a careful balance where they balance each other out so that our blood stays the thinness it needs, that you don't bleed too much, you don't clot too much. It's really a miraculous, impressive balance going on. But when this gets thrown off balance, you can get hypercoagulable states. This can be genetic hypercoagulable states, where you have too much blood clotting factors. All right, this could be induced hypercoagulable states. All right. In addition to that, blood likes to flow. If you get stasis or stagnation of that blood, venous stasis, stagnation in the veins, this can lead to blood clotting too. This is why prolonged periods of immobilization can lead to blood clotting. If you're, in bed not moving for multiple days. Some people say long plane rides or car rides, although that's up for debate a little bit. And then endothelial injury. This is injury to the blood vessel wall. So you have blood vessels, right? Blood vessels are lined by endothelial cells. These are the cells that line all the blood vessels. All right, and they're cells just like any other cells. They got nuclei. And when they get injured, let's say you get a cut or an injury, that injury releases a bunch of factors because what your body wants to do is clot off that area so that you don't bleed. But sometimes those factors can get into the rest of the blood vessel and lead to a procoagulant state, right? Throw off that delicate balance and be more clotting. So that's Virchow's Triad: hypercoagulability, venous stasis, and endothelial injury. And we think about pulmonary emboli, we're talking about the lungs, but actually the vast majority of these clots originate in the legs or the blood vessels of the pelvis. In the legs and pelvis, we call it a DVT, or a deep vein thrombosis. DVT, deep vein thrombosis. And what happens is if we have a person here, and here's their lungs, right, and here's their legs, the blood vessels in the legs lead up to the heart that then travels into the lungs. So a clot down here in the blood vessel of the leg can travel up through the heart and go into the lung. And that's where the majority of pulmonary embolism starts. It starts in the legs. So someone sees a swollen leg, they don't get it checked out, and then it's actually a blood clot. And that blood clot then travels up the body, through the heart, into the lungs, and leads to a pulmonary embolism. The other risk factors that we see associated with pulmonary embolism, we mentioned periods of immobility, that Virchow's Triad, venous stasis. Surgeries can lead to increase your risk for blood clots. Sometimes that's because of endothelial injury and some of the inflammatory response you get from surgeries. Cancers. Cancers often cause a hypercoagulable state, so that can increase your risk for blood clots. Pregnancy, same thing. Older age is a risk factor. Obesity, smoking, prior VTE. VT stands for venous thromboembolism, VTE, venous thromboembolism. And this is just prior pulmonary embolism or prior deep vein thrombosis. Anyone who has history of it has an increased risk. The other thing we see is oral contraceptives, birth control pills, increase risk for blood clots. And so we do see at times young females who are on birth control pills who have no other risk factors that get a significant PE. So that's definitely something to keep in mind, especially young females on oral contraceptives who also smoke or who are also obese. Some of those things, when added together, can really increase our risk for pulmonary embolism or blood clots. All right, what about the pathophysiology? All right, what happens when you have a pulmonary embolism or blood clot in the lung? Well, what happens is it throws off a couple things. We're going to divide this into the lung and the heart, and we're going to start with the heart because that might sound confusing. And that is because the heart, as we said, has a right side, the right side of the heart, and a left side. And the right side of the heart pumps blood to the lungs, whereas the left side of the heart pumps blood to the rest of the body. All right, so the right ventricle pumps blood through the pulmonary arteries to the lungs. And if you get a blood clot in the lungs, and if it's a big blood clot, the heart's a motor and the blood vessels are pipes. So if we just pretend like the heart's a motor, we'll draw another heart, right? This is the motor. And the heart pumps blood through the blood vessels with this, which is a pipe. So we'll label it motor, pipe. If this motor is pumping blood through here, but a big clot develops, that motor is still trying to pump blood through here, and it has to go into overdrive, and it causes strain on that motor. And that motor then starts to suffer damage. And that's why the right side of the heart, when you have a pulmonary embolism, can lead to right heart strain or right heart failure, or even cardiogenic shock, which is when the right heart, well, I guess for the sake of appropriateness, we're going to relabel that this obstructive shock, which is when the right heart cannot pump blood past those blood clots, and it starts to dilate and fail, and you get right heart failure, which then leads to obstructive shock. And this is what you can die from. People go into cardiac arrest from this. So the first part of the pathophysiology is the heart, that right side of the heart that pumps blood to the lungs. When it's trying to pump blood against big blood clots, it becomes strained, suffers damage. You can call into right heart failure, and the most extreme version of right heart failure is obstructive shock. The second part is the lungs themselves. Excuse us, we just had to get a drink. So the lungs need perfusion in the form of blood flow. If we go over here, we see lungs here, and then we kind of zoom in into what we call alveoli. And these alveoli are these small balloon-like structures. And these are the structures that inflate and deflate for gas exchange, right? We breathe air into the trachea that goes into the bronchi, bronchioles, and eventually travels down to the alveoli. And that oxygen gets brought into the blood vessels, and then carbon dioxide from those blood vessels goes into the alveoli, and then you breathe that carbon dioxide out, right? And you breathe CO2 out. So O2 in, CO2 out. But to do that, you need blood flowing through these blood vessels. You can see all these blood vessels coating the alveoli in blue and red here. Because as we said, there's carbon dioxide in the blood vessels that need to drain out. And then there's oxygen in the alveoli that need to go into the blood vessel. That is called ventilation perfusion matching, right? The V for VQ stands for ventilation, and the Q stands for perfusion. I'm sure there's a reason for why it's a Q. I didn't look it up ahead of time, and I'm not sure what it is, but if anyone knows, leave it in the comment. When you have a bad blood clot, you get ventilation perfusion mismatching. Because what happens is you have a huge blood clot in this blood vessel, right? So there's no longer blood flowing through this blood vessel, and that means there's no longer blood getting to the alveoli for gas exchange. So the oxygen in the alveoli can no longer go into the blood vessel because there's no blood flow, and the carbon dioxide in the blood vessel can no longer go into the alveoli, so you can't exchange gas. So those alveoli keep breathing air in and out, but there's no blood flow to them to exchange gas. So you get a mismatch of your ventilation because you're still ventilating these areas, but you're not perfusing them. There's no blood flow, so they're not participating in gas exchange. And this can lead to hypoxemia or low blood oxygen levels. It also can lead to hypercapnia, although less commonly, or high carbon dioxide levels. And then, as we mentioned, increased pulmonary vascular resistance. This essentially just means that the resistance of the vasculature in the pulmonary or the lungs is high, leading to that right heart strain like we talked about. All right, so that's the pathophysiology of pulmonary embolism. What about the signs and symptoms? What should we be looking out for to diagnose this? Well, there's a whole bunch of things. And the overarching message here is all these have poor sensitivity and poor specificity, meaning there's no one sign or symptom that will be, yes, this is a PE, no, this isn't a PE, right? None of them are highly sensitive to detect PE, and none of them are highly specific to confirm PE. But all of these can be associated with pulmonary embolism. So shortness of breath or dyspnea. This can be sudden in onset, where it just comes in like snap of the fingers, or it can be gradual in onset. We see this in hospitals. Sometimes people are like, just out of nowhere, 2 hours ago, I just couldn't breathe. And other people are like, oh, 2 weeks, gradually over time, I've had worsening difficulty breathing. Chest pain's a big one. Sharp stabbing, particularly this portion, may worsen with deep breaths. This is called pleuritic chest pain, pain with deep breaths. And although still poor sensitivity and specificity, this is one of those classical symptoms people associate with pulmonary embolism. Rapid heart rate or tachycardia, cough, particularly hemoptysis or coughing up blood. This can happen from a number of conditions: pneumonia, bronchiectasis, bronchitis, lung cancer, but it also can be from pulmonary embolism. And it's one of those symptoms associated with pulmonary embolism. Hypoxemia, low blood oxygen levels. Anxiety or a sense of doom people talk about without a clear thing, and that's probably because of the shortness of breath you feel. Dizziness or syncope, especially syncope. Syncope is where you faint or lose consciousness, and this can be a really severe thing if it is from a pulmonary embolism. Now, syncope is much more commonly from other things, but if it is from pulmonary embolism, it can suggest a big degree of severity. Leg pain or swelling. We said most pulmonary emboli start in the leg, and it's usually one leg, unilateral. So that's something to look out for. Cyanosis or blue discoloration. This is from hypoxemia or hypoxia. Not as common. We don't see it too much. You can get low-grade fevers with pulmonary embolism, diaphoresis or sweating. Not a big thing to worry about. Jugular venous distension essentially is a sign of that right heart or any heart failure, but it can be associated with right heart failure, which is why it can be a symptom or a sign of pulmonary embolism. And then they say crackles or rails, but we don't see this very often, so we're going to cross that one out. But these are all signs and symptoms of pulmonary embolism. The ones that people talk about the most are pleuritic chest pain, hemoptysis, are two big ones, and then tachycardia or rapid heart rate. Again, all these things can be present and none of them have a good enough sensitivity or specificity. All right, so now that you've seen the signs or symptoms, how do you actually evaluate the patient you're worried about pulmonary embolism? Well, there's a couple different scoring systems that we use. And this is not meant to be medical advice per usual. None of this is meant to be medical advice. So we're just going to go through these scoring systems. And the first is called the PERC criteria, P-E-R-C, PERC. And this was criteria that was studied. And it involves age less than 50, heart rate less than 100, oxygen saturation greater than 95%, no leg swelling, no hemoptysis, no recent surgery, no history of VTE, and no use of oral contraceptive pills. If the answer is no to all of these, and it has to be all of these, PERC 0, all of these are no, all of these are negative, then a lot of people would suggest this rules out pulmonary embolism. You don't need to continue working it up. But in reality, when they study it, it just means that the risk of pulmonary embolism is really less than 1 or 2%. So we do use PERC 0 as a rule-out criteria, and it's been studied that way, and a lot of societies endorse it in that manner. So if you're PERC 0, a lot of people would suggest you do not need to further work up pulmonary embolism. Okay, but just know that this is not 100%. It's close to 100% to rule out pulmonary embolism, but it's not 100%. But we do use it in that context, especially with low pretest probability, or if your pretest probability, which is how much you think this is PE, is less than 15%. All right, what if the PERC score or criteria is not 0? Let's say it's even just 1 or more than 1. Well, then you can't rule out pulmonary embolism. So then you have to go to your next tool in your toolbox. And that's usually this thing called the Wells criteria for PE. There's one for DVT as well, but Wells. And the Wells is another series of signs and symptoms that have different points associated with them. And this is, are there signs or symptoms of DVT? If so, 3 points. Is PE the most likely diagnosis? And this is based on physician or clinician gestalt, what they think is the most likely diagnosis, 3 points. Is the heart rate greater than 100, 1.5 points? Have they been immobilized or had surgery, 1.5 points? Is there history of a previous PE or DVT, 1.5? Do they have hemoptysis or bloody sputum? And then is there active malignancy? And what you do is if someone has signs or symptoms of DVT and they get 3 points, and they also have hemoptysis and they get 1 point, you essentially add up all the points that they have, add up points. And then you go to the interpretation of the score. And if it's less than 2 points, PE is highly unlikely, right? Less than 1.3% of patients who have less than 2 points on the Wells score have a PE, so highly unlikely. If they have 2 to 6 points, this is moderate. PE is possible, about 6.2% prevalence. And if they have high probability, more than 6 points, PE is fairly likely, still only 37%, but a lot more likely. So you can use the Wells score to understand the probability of pulmonary embolism, and using that probability, you can consider either Ddimer testing or going to imaging. All right. Some people use this 4-point cutoff. If you're less than 4 points, use Ddimer. Ddimer is a blood test. It is non-specific. It can be high in infection, inflammation, trauma, and also pulmonary embolism. But if the Ddimer is negative, depending on what your assay is, and there's other things that can use. There's another thing called the years criteria, which changes Ddimer cutoffs a little bit. We're not going to talk about it here. But if your Ddimer is negative and your Wells score is less than 4, that's decent at possibly ruling out PE, that you don't need to proceed to imaging. But if your PE Wells score is greater than 4, the recommendation would be to consider CT, CAT scan, pulmonary artery. This is a CTA of the chest. Okay, that's where you lay in the CAT scan tube and it shoots dye contrast into your blood vessels and it looks for clotting in those lung blood vessels. This has a negative predictive value of 96%, not 100, but close to that, so it's a really good test. But it does have contrast, and some people are allergic to contrast. Some people believe contrast can damage the kidneys. That's a topic for a different lecture. But it does have contrast, so you got to be cognizant of that. So this is a common thing that we use in the hospital. If PERC, right? Remember PERC up here. If PERC is 0, a lot of times we say PE is ruled out. Don't need to continue any additional workup. Okay. If Wells is less than 4, if PERC is not 0, move on to the Wells. If Wells is less than 4, get a Ddimer. If the Ddimer is negative, PE can possibly be ruled out. If the Wells is greater than 4, proceed directly to CT imaging to see if you can diagnose and see a pulmonary embolism. Again, not medical advice. All this has some degree of shortcoming, and there's lots of intricacies to this, but this is a general structure that is often used. All right, once you diagnose PE, how do you manage it? Well, the big capstone to management of pulmonary embolism is anticoagulation, right? You have a blood clot, so you need to anticoagulate to thin the blood to try to prevent additional blood clots or propagations of blood clots. And you can do this using a lot of things. You can use DOACs or direct oral anticoagulants, DOAC, direct oral anticoagulant. These are things like apixaban, which is brand name Eliquis, or rivaroxaban, which is brand name Xarelto, or warfarin, which is brand name Coumadin, unless we reverse those. Can't remember if it's Coumadin, brand name warfarin, or vice versa. Shame on us. But you can use a DOAC, or as we said, you can use Coumadin, which is a vitamin K inhibitor, maybe would be the correct term. You can use heparin to do this too. But you need to anticoagulate, assuming there's no contraindication anticoagulation, such as frequent bleeding. If the PE is massive, and this is something we're going to talk about in a future PE lecture, so definitely subscribe and stay tuned for that. Sometimes you need to thrombolyse these patients, which is where you give them a clot buster like TPA to actually break up the clot. But this does increase your bleed risk a lot, so we save it for patients who have massive PEs. If you have like submassive or intermediate risk, again, future videos, so stay tuned. Sometimes we do thrombectomy. This is where you actually go into the blood vessels with a catheter and try to suck out that blood clot. Or catheter-directed thrombolysis, which is where you go into these blood vessels and you put catheters right next to the blood clot and kind of spray them with clot buster. Or at the most extreme, you can go to the operating room and get a sternotomy and an embolectomy, which is where they actually cut into the blood vessels of the lungs and remove the clot. How long you're on anticoagulation for, again, outside of this video a little bit, but it depends somewhat on if it's provoked or unprovoked. Provoked would be like you got surgery and then developed a blood clot. Unprovoked was there's, nothing, right? Provoked would be that you maybe have cancer, right? Provoked would be that maybe you were immobilized. So they identified something that provoked the DVT. When it's an unprovoked DVT, 3 months of anticoagulation is something you'll often hear, although definitely talk about it with your physician because there's a lot of nuance here. When it's unprovoked, people don't necessarily know how long to do anticoagulation for. Should you do 3 months? Should you do lifetime? It's usually a conversation between a patient and physician that balances their bleed risk as well as their clotting risk to understand. A lot of these patients will end up on lifelong anticoagulation to prevent future episodes of pulmonary embolism. Because again, once you have one, like we talked about, you're higher risk to have another. So if we talk about prognosis, how patients do in the acute setting, there's another score that's kind of well elucidated. It's called the PESI score. This stands for Pulmonary Embolism Severity Index, or PESI. And what this looks at are a number of risk factors, and again, then they score them with points. And depending on the number of points you have, helps us understand your risk. So the risk factors here are age, and the points you get is actually your age in years. If you're 70, it's 70 points. If you're male sex, 10 points. If you have active cancer, 30 points. Heart failure, 10. Chronic lung disease, 10 points. Heart rate greater than 110, 20 points. Systolic blood pressure less than 100, 30 points. Respiratory rate greater than 30. Temperature, altered mental status, oxygen saturation. So you can see the PESI score is divided up somewhat into patient characteristics and previous diseases, and then into kind of clinical features. And the score then helps you predict the 30-day mortality risk, or how likely someone is to die within 30 days. If you have less than 65 points on the PESI score, that's very low risk, and your mortality at 30 days is 0 to 1.6%. Whereas if you have more than 125 points on the PESI score, that's very high risk, and your mortality at 30 days is up to 25%. And it helps here understand, can you treat it as an outpatient, right? Maybe with some low risk PESI scores, you can consider outpatient treatment versus hospitalizing versus ICU, intensive care unit level care, right? So the PESI score is a way to help understand the 30-day mortality risk in patients with acute pulmonary embolism. And you can look all this up, no need to try to memorize it. And then complications, we just wanted to list a few of them here. This is another lecture for a future time point, so again, keep an eye out for that. But there's a couple complications. The big one is recurrence, and we talked about this. Even if you have anticoagulation, you can have recurrence. If you stop anticoagulation, you certainly can have recurrence. And when it recurs, a lot of times the morbidity mortality is a lot worse. We talked about how you can have right heart dysfunction or right heart failure. Again, that right heart is pumping blood to the lungs, so if those blood vessels in the lungs have clots, that right heart is trying to pump blood past those clots, and it causes strain, dysfunction, and can cause right heart failure. And then the third is something we haven't talked about, chronic thromboembolic pulmonary hypertension, or CTEPH. This is where over time, those blood clots lead to high pulmonary vascular resistance, PVR. And again, this is an advanced topic, but when you have high PVR, it can lead to pulmonary hypertension. And over time, that pulmonary hypertension can then lead to right heart failure, as well as a bunch of other stuff, chronic shortness of breath, low oxygen levels, et cetera, et cetera. So pulmonary embolism, even if I shouldn't say even if, but when patients survive kind of acute pulmonary embolism, there are some longer term complications to really keep in mind. Some we didn't list here if you are on anticoagulation, but bleeding for those on anticoagulation is another complication, right? When you take anticoagulation to try to limit recurrence, that can then lead to bleeding. So sometimes chasing our tails a little bit. Hopefully that was helpful, educational, the basics of pulmonary embolism. Let us know what thoughts, comments, questions you have down below. Subscribe, hit the bell button, check out that Patreon page. We'll make sure we get all these video notes on there and get some practice questions up. So definitely check that out. All that stuff linked in the video description. And in any case, stay well, keep learning, and we'll see you next time.